Hello everyone. So today we'll be studying about uterine inversion. This is our week 3 in the series of one topic a week. So today we'll be going ahead with uterine inversion. Very important topic. What is uterine inversion? Uterine inversion is when the uterus turns inside out. Inside out means this inner uterine lining, it happens after delivery. So when this inner uterine lining comes out after delivery, this comes out, it is called as uterine inversion. Do not confuse it with uterine prolapse. Prolapse is when this normal uterus, due to weakening of the surrounding ligaments, when this uterus comes out, why it has come out? Because the ligaments have weakened. So it comes out, that is uterine prolapse. But inversion is when the inside surface comes out. Like, okay, I can explain you in this. This is my daughter's bag. She'll kill me if she'll know I've used it this way. So this is a bag. This is normal uterus standing in its position. But due to some reason, when this inside surface comes out, suppose there was something attached here and it is pulled so roughly that this inside surface comes out like this. So it is totally inside out. It pura invert ho gaya. It has come inside out like this. This is uterine inversion. This is not prolapse. This inside surface has come out. Why? Because something was attached here and you were pulling it so fiercely, you are pulling it so harshly that it has brought the inside surface out. This is called as uterine inversion. Let me correct it now. Yes. Okay, so never confuse it with the prolapse. It can be of 3 types depending on the duration. If you have discovered it within 24 hours of delivery, which is the most common type, it is called as acute. If it is diagnosed between 24 hours to 1 month, it is subacute. If it is diagnosed after 1 month, it is called as chronic. Okay, so it can be of 3 types. So why does uterine prolapse happen? Uterine prolapse happens when you are trying to pull the placenta and the placenta is not coming out. Okay, so when there is some roughness, some protocols are not being followed for the 3rd stage of labor, then the prolapse happen. So risk factors are when the cord is short, when there is a short cord and you are pulling it constantly, when the placenta is attached at the fundus, when it is a retained or an adherent placenta. These are the risk factors. But the cause is, remember, the cause is basically mismanagement of 3rd stage of labor. If the 3rd stage of labor, which is the stage where placenta is delivered, it is not managed properly, uterine inversion will happen. If you remember the steps of active management of 3rd stage of labor, what was there? One of the steps was controlled cord traction. What is controlled cord traction? That when you apply traction on the cord, it is very controlled. You don't pull it, you just apply a traction. Aapne bas ek traction lagaya hua hai, you are not pulling it out. Okay, you just apply a traction. जब वो अपने आप separate होगा, it will itself come out. And your one hand is on the uterine fundus. Right? You are pushing it back and with one hand you are just applying the traction. This is कहते हैं controlled cord traction. And the aim of controlled cord traction is to prevent inversion. This is the aim. And if it has not been followed, the 3rd stage of labor has not been managed properly, it will result in uterine inversion. Right? Okay. How will it present? Obviously, uterus has come inside out. What the patient will have? Patient will bleed profusely. Patient will present as PPH. But one important thing is, because the whole surface has come out, there is so much traction on the ovarian ligaments. Everything has happened so acutely. It is not something chronic. Prolapse की तरह नहीं है कि धीरे धीरे it has come out. It has acutely come out. There is so much traction, there is so much force on the neurovascular bundle, it will result in shock. And this shock will be disproportionate compared to the blood loss. You will see that blood loss has happened, but it's not that significant that the mother is going into shock. Because this shock is actually not hemorrhagic shock, it is actually the neurogenic shock. So whenever you see in the question that shock was disproportionate to the blood loss, think it is something else. It is not PPH, right? Okay. When you do the examination, when the patient has presented to you with shock and PPH, first thing is you put hand on the abdomen. You want to see whether the uterus is contracted or not. So when you put your hand on the abdomen, you will see the uterus is not there. You can't feel the uterus. or you feel the fundal notching. If the uterus is there, you can feel this notching. It means the inside surface is trying to come out. On the local examination, you can see this shaggy mass because this is the inner surface. And here it is not visible many times. Maximum times the placenta is attached here. Maximum time the placenta is attached here. Placenta has not separated, and along with placenta a shaggy mass come out, and that is uterine inversion. Okay, so mother will present with PPH, but compared to the blood loss, mother will be actually in shock, right? Then on examination you will not be able to feel the uterus, and on PS, on local examination, a shaggy mass is seen coming out of the introitus. Again, the degree of inversion depends on how much the uterine surface has come out. Grade 1 is when there is only notching of the fundus. That is grade 1. Grade 2 is when the inside surface has come up till the cervix. जब वो cervix तक आ चुका है. When the inversion has reached the cervix, that is grade 2. When it has come out of the cervix in the vagina, it is grade 3. And when it has come out of the introitus, when it is visible to you, okay, without doing any PS, when it is visible to you, that is grade 4. So when it is out, it has reached the cervix, it is grade 2. When it is out of the cervix in the vagina, grade 3. When it is out of the vagina, it is grade 4. Okay. Yeah. So the questions are asked on the management, because when you are working, see, ये जो complications होते हैं, generally they happen at the periphery. So when you will be posted as a medical officer, or maybe in your rural posting, anytime when you are sitting in a district hospital, you can face such situations. So you should know the primary managements, what should be done. So as soon as you see uterine inversion, what will be your first step? Always ask for help. You will be needing a lot of assistance, you will be needing a lot of help. So always ask for help. Start the fluid. Okay. What about oxytocin? In the active management of third stage of labor, either you give IM oxytocin, many times IV infusion is started. IM दे दिया तो कुछ नहीं कर सकते, you can't do anything. But if IV oxytocin infusion is going on, what will you do to this IV oxytocin which is being given to the patient? You will stop it. Why will you stop it? Because now the uterus is inside out. You have to reposit it. For repositing it, you need a relaxed uterus. If it is tight, remember how tight my bag was and how tough it was to manipulate it. So you want a relaxed uterus so that you can reposit it. That is why you always stop the oxytocin. If any infusion is going on with the patient, you stop it. You start the IV fluid. You arrange for blood. Okay, you put the IV cannulas, general management, you put 2 wide bore IV cannulas, start the fluid, arrange for blood, stop oxytocin. What about placenta? I told you, when the uterine inversion happen, in majority cases, placenta is still attached. Will you first remove the placenta? No. Your attempt of removing the placenta resulted in such a worsening condition. If you will try to remove it more, it will put more traction on the neurovascular bundle. So now you will not touch the placenta. Now you will not pull it out. So do not remove the placenta. You reposit the uterus with placenta attached. So your next step will be, you reposit the placenta. You reposit the placenta then and there. You do not need to shift the patient to OT. You don't have that much time. You do not need to shift the patient to a tertiary care center. No. Where the inversion has happened, there only you reposit it immediately, because otherwise uterus will contract and you will not be able to reposit. So you reposit it then and there using your hand. So let the placenta be attached, wear a glove and just push the whole uterus inside using your hand. Then and there, not in the OT. इसी कहते हैं Johnson's method. ठीक है? So what you did, you stopped the oxytocin, you did the general management of IV fluid, arranging blood, you do not remove the placenta, and then and there in the labor room, you use your hand and reposit the uterus. You keep your hand inside till the uterus is well contracted. If your effort of repositing the uterus is not being successful, then you take the patient to OT. So if you're trying to reposit it in the labor room and it is not getting back, that is maybe because uterus is contracted. You will now need a general anesthesia. So now you will take her to OT. So remember, uterine inversion is managed there in the labor room. Okay. So every line is very important. So according to this is our own Foxy recent guidelines that has been given for uterine inversion. Read the steps. Call for help. Stop oxytocin. That is the exact steps that are written in these Indian guidelines. Then secure 2 IV lines. Okay. Restore circulation. Okay. Correct. Then do not remove the placenta. Do not remove the attached placenta. Reposit the uterus immediately in the labor room. That's what they have written. And that's what the previous question was also asked. You reposit it in the labor room itself. If your reposition has failed, then you take her to operation theatre for general anesthesia. So these are the general steps. Clear? Now what methods you use for reposition? One I have already told you is using your hand. These are non-surgical method. You can either use hand or saline. So when you use your hand, you hold the segment that has come out and then you reposit it using your hand. The segment that has come out first, you reposit it that part first and then you reposit eventually whole of the segment using your hand. इसे कहते हैं Johnson's maneuver. Very easy to do. So what will you do? Patient will need good analgesia, good anesthesia. Okay. Either try it doing without general anesthesia. If not successful, give general anesthesia in the OT and then try it. Then stop oxytocin. You have stopped the oxytocin. Once your hand is inside, now start the oxytocin so that the uterus contract. So once your hand is inside, start the oxytocin infusion. And once the uterus is contracted, then remove your hand. And after removing your hand, now remove the placenta. So once uterus is contracted, remove your hand and now slowly and gently remove the placenta. Since you have done a lot of maneuvers, you will make sure that you will keep the patient on antibiotics and you will keep the patient on uterotonics for at least 12 hours. Okay, so you will continue oxytocin for 12 hours and also you will give this woman antibiotics since your whole hand has been inserted inside uterus. This is Johnson maneuver. Another method is using a saline. When inversion is especially done in mild inversions. When inversion is not severe, there has been only grade 1 or 2 inversion. What do you use instead of hand? You use saline. You put the saline bottle above, just 150 meters above the patient. You put the saline bottle at quite a good height of the patient and then you let the saline come inside the patient very forcefully. You put it around 1 to 1.5 meter high and then the saline flows forcefully inside the uterine cavity. So you use a ventouse cup. Can you see? You use a ventouse cup so that the saline goes inside the uterine cavity and it doesn't come out. It goes so forcefully inside the uterine cavity that it pushes the segment again back to its place. So here you use saline instead of hand for repositing the uterus again. And you use ventouse cup for infusion of saline. Again, once it is reverted, once it has been in its position, you start the oxytocin and you also remove the placenta once the uterus is contracted. Again, you will continue the oxytocin for 12 hours and start the patient on antibiotics also. If these methods have failed, even under general anesthesia, if Johnson's method has failed, you go for surgical method. Means you do a laparotomy. You do a laparotomy and you see something like this. Can you see the uterus going inside? Can you see the fallopian tubes going inside? So that's what you see. So there are 2 methods. You don't need to know detail. Just remember Huntington's and Holton's operation. What do you do in Huntington's? If you're not able to push from below because uterus is tight, you pull from above. You do a laparotomy, open it up using LEs attaching here and here, you pull from above. So one person will push from below the segment and one person will pull from above. That is Huntington's technique. Many times Huntington's technique is also not successful. Why? Because a constriction ring forms here. Because of the delay, the constriction ring forms here, you need to cut it. So you make a cut on the posterior aspect of this constriction ring. Posterior इसलिए क्योंकि anteriorly bladder है. You will cut the bladder. So posteriorly you will make a cut and जैसे आप cut मारोगे constriction ring will open. Now you pull it out. And once you pull it out, the inversion, you will be able to revert the uterus. इसे कहते हैं हॉल्टेंस. सो हंटिंगटन्स में you simply pull it from above, but in Halltens you first make a cut on the constriction ring, always on the posterior aspect, and then you pull it. So these are the surgical methods that have to be done when your non-surgical methods fail. That's it. That's it all about uterine inversion. So if I conclude what all you have to do, first, it is always managed at the place of birth. So wherever the birth has taken place, whether in the labor room or in the home, you have to manage it there only. You do not refer the patient anywhere. Okay, you have to manage it quickly. Second step, placenta is separated only when the uterus is reposited and contracted. आप placenta तभी separate करोगे when uterus is back in its position. Then in case this fails, then you take the patient to OT. Okay, otherwise you don't need to take the patient to OT. So that's it. That's it all about uterine inversion. I hope this topic is easy for you now.